So, ladies and gentlemen, welcome to this session of the ERC Congress 2020. It's a great pleasure for me to share this session together with Siobhan Masterson from Ireland. My name is Jan Thorsten Gräßner. I'm coming from Germany. I'm the director of the Institute of Emergency Medicine at the University Hospital in Kiel. We have a fantastic group of speakers today or tonight, depending on your time when you're watching us. And we will start with Ingvild Kjæveland from Norway. Ingvild is the leader of the Norwegian Resuscitation Registries. She's also the national coordinator for the Eureka study 1 and 2 in Norway, and she's a member of the study management team of Eureka and the Eureka network. She started her PhD to be a PhD student at Oslo University, and I'm really proud about that this is in collaboration with our university hospital in Kiel. So Ingvild, we are happy to see your slides, and we invite all of the participants to use that chat function or this Q&A function that you send us questions. We discussed with all the presentators before that session that we will listen to all presentations and discuss everything together at the end. So enjoy the session, Ingvild. It's up to you, and we will listen, follow, and I hope we have a lot of questions.
Thank you so much, Jan Thorsten. And I am a proud PhD student, and Jan Thorsten is one of my tutors. So I've been asked today to talk to you about out-of-hospital cardiac arrest outcomes in Europe. Next slide, please. So when we talk about outcome can be a lot of different things. I hope you go into my video afterwards where it will be explained a bit more. But this is some of the outcomes I'd like to discuss with you. One outcome can be the bystander CPR rate. And in the latest Eureka study, we found that 58% of the patients got CPR before EMS arrival. The range was from 13 to 83%. Most of the countries all the way at the top are the Scandinavian countries, and we're still looking into why we are so good at doing CPR before EMS arrival. One of the other outcomes we can look at is the median response time of under 10 minutes. This varies a lot, and very few countries actually have a median response time of under 10 minutes. If you look at bystander CPR and response time together, the longer the response time, the better chance you have of actually getting bystander CPR. It takes longer, and dispatch can help you start CPR. So there might be some issues with these two outcomes together. And then we can look at ROSC, which is the most common way of looking at outcome. In Eureka, we found a ROSC rate of 33%, and there was a huge variation from 8 to 42%. And then we looked at 30-day survival or survival to hospital discharge, whichever one was available. And we found this to be 8% in this study. The range was from 0 to 18%. Next slide. We also did a survey in 28 countries in Europe looking at the registries. Do you have a registry? How do you collect the data? How do we know that what you report as outcome is actually available for the whole country? And I was surprised to find that only 6 countries have a national registry covering the entire population. And very many countries still have a way to go to achieve full coverage of a national registry. Next, please. So very, very short summary. We found an average survival rate of 8% from 0 to 18% in Eureka study. Compared to the rest of the world, which I know will be presented also later today, it varies. Asia reports 3 to 6%, the US reports about 11%, and Australia and New Zealand report about 12% survival to 30 days or hospital discharge. So is Europe worse than Australia or New Zealand? I'm not quite sure. It might actually be what we're counting. So we really, really need to look at how we count, what we count, and how this is calculated. So thank you.
Ingrid, thanks again. So it's yeah, it's surprising this new way how we present the slides. So yes, short, and if you need more information, and I engage you and suggest you to do that, please read the original slides on the webpage. So Ingrid, thanks again. And as we discussed before, we direct handle over to the next speaker, and the next speaker will be Lars Andersen. He is an associate professor at the University Hospital of Aarhus in Denmark. His research primarily focused on advanced life support, and he's a member of the ALS task force at ILCOR. Lars has been involved in a lot of studies, and he's a regularly statistical reviewer for JAMA. And if he's not doing this, he's a clinician working in anesthesia and critical care. And Lars, it's your stage, and we are interested what you are presenting us.
Yes, thank you very much, and thanks for that introduction. If you could put up my slides, that would be great. So my topic is a little bit different than the rest of the groups, as it is focusing on in-hospital cardiac arrest. And I hope you had a chance to watch the full presentation, or will do after the talk. Here I'll just provide a few slides from that and hope that will sort of wake your interest in that. Next slide. So let's go one back. Oh, it's going by itself, it looks like. But we can do it without the slides if it's going too fast. So importantly, the first thing to know is really if in-hospital cardiac arrest is a major problem. And there's no doubt that it is. Luckily, there has been new registries over the last few years looking at in-hospital cardiac arrest. We don't have the number of registries that we have in out-of-hospital cardiac arrest, but we do have some. And one of the most important registries is the Get With The Guidelines registry from the United States. And based on that, we were able to sort of extrapolate to the entire country of the US to figure out how many in-hospital cardiac arrests there were in the publications we published a few years ago. So there's about 300,000 in-hospital cardiac arrests each year in the United States. And there's also some other registries that have been looking at this, the UK registry and the Danish registry. Somewhat surprisingly, the numbers are quite different in these countries if you compare it to the number of hospitalizations. So it's somewhere between 1 and 10 of the people who are hospitalized who will have an in-hospital cardiac arrest. Unfortunately, the outcomes are not great. Depending on the registry and the definitions used, the outcomes are often between 20 and 30% surviving to hospital discharge. And there has been a great improvement in outcomes over the last 2 decades. But as you can see in one of my slides, somewhat provocative slide, this might have started to plateau, and we're not seeing the same increase we did from 2005 to 2010. We haven't seen that in the last 5 or 10 years. And I think that is both good in the sense that we have gotten a better survival, but also somewhat concerning that we're not getting better. So outcomes in-hospital cardiac arrest are in many ways similar to out-of-hospital cardiac arrest when it comes to the predictors of outcomes. So some of the things that are associated with better outcomes are shockable rhythm, whether the cardiac arrest was witnessed, and of course, also whether it was monitored. Those things are sort of correlated in some way. So why is it that outcome hasn't improved for cardiac arrest over the last 5 to 10 years? Well, we really don't know. But one of the things is that we really don't have a lot of evidence for the treatment of in-hospital cardiac arrest. There's only maybe a handful, maybe 10 studies, randomized clinical trials, either during cardiac arrest or after cardiac arrest, that has really focused on the in-hospital cardiac arrest setting. And I think that is very problematic when you consider how many patients have an in-hospital cardiac arrest and the poor outcomes, as I just explained. So I think going forward, we have to focus more on in-hospital cardiac arrest and make sure that we also include those patients in clinical trials and registries going forward. Thank you.
Lars, thank you for that presentation. There was a question from one of the audience at this stage, if they can see your slides again, but I suggest that in the whole presentation, what we have online on the web page, there everything is included. So for that participant, go on the web page and watch and listen to the whole presentation. Okay. It's fast, but not too fast. We come to speaker number 3. It's Kirsty Haywood. She's a reader at Warwick Medical School, is leading a program of work focused on health outcome assessment. And often you hear her name in collaboration or in contact with Core Outcome Set for Cardiac Arrest, the COSCA project. So looking on the patient's perspective and giving us an idea that not only looking on ROSC survival rate, 30-day survival, and a yes or no is enough for analyzing our results. And Kirsty, we know each other for some years, and we know your patient's perspective, and I'm really interested in your presentation.
Thank you, JT. It reminds me of the first time that we met. Can I get my slides, JT?
It's not up to me.
Oh,
but he will put them directly on the screen. Helen, can you help us? If you don't put them on, you can share your screen and use it like this way. The ERC just sent us an SMS that the slides are not there, so maybe you can share your screen.
Okay, gosh, I could just talk to it, shall I? I'm not sure I'm going to be able to get my slides up that quickly. Share my slides, okay. Let's just talk to it. Okay.
If you can, Kirsty, it's fine. It's fine.
Okay. So the first slide was just summarising. The key slides have been taken out of the main presentation anyway, so you can access them there. The first slide was just summarising the core outcome set. And it was just highlighting the fact that historically outcome reporting in this field has been dominated by clinician reported outcome, as JT alludes to, and short-term outcomes at that. And that a lack of reporting outcome guidance was accompanied by this significant heterogeneity in the way in which outcomes were reported, but also importantly, a failure to really capture the impact of survival, not only over the longer term, but from the perspective of survivors. And so working collaboratively with key stakeholders, including survivors and their advocates and health professionals and researchers from across the field, we collaboratively led to the development of the core outcome set for cardiac arrest, where we sought to achieve consensus on the most important outcomes that should be included in clinical trials, cardiac arrest clinical trials moving forward. Happily, there are now two COSCA sets available, one for adults published in 2018, and more recently one for pediatric research, PCOSCA, recently published in Circulation, and a project that was ably led by Alex Topjian. I apologise for your pronunciation. And reassuringly, there's some consistency across those two outcome sets, both including survival, neurological or brain function, and quality of life or life impact over the longer term. And within PCOSCA, the life impact is further specified as cognitive function, physical function, and basic life skills, which are, as you would expect, important components of quality of life. So the COSCA initiatives represent an important step towards ensuring that there's consistency in outcome reporting across the studies, but also sought to highlight the importance of survivor-reported evidence and determining the outcomes that really matter over the longer term following cardiac arrest, and the ones that we should really be thinking about to inform practice. Okay, so the next slide was just the bubbles with all the key elements that we know that are affected. So we know that survivorship following cardiac arrest embraces a whole range of different concepts of, and I'm going to quickly just bullet point through them. So cognitive impairment is the most commonly reported residual problem, with estimates of up to 76% of survivors experiencing some degree of cognitive impairment at 6 months. The variations are largely due to differences in reporting and outcome assessment and the different cohorts. But there appears to be a little bit of improvement up to 12 months, but longer term studies are lacking. But the guidelines now recommend that routine screening, pre-hospital discharge, and both in the early term and long term are to be recommended. Anxiety and depression is very common, with high levels of anxiety reported even at 12 months post-arrest, and I suspect further on, although we have very few long-term studies. And again, we don't really understand the true prevalence of anxiety, depression, and emotional impact in this field because the studies just don't exist, or they use, again, a range of different reporting approaches. Of note, long-term post-traumatic stress is more commonly reported in caregivers, and we know from qualitative evidence that actually that can be really quite significant. There's very limited data in this field with regards to the physical impact of cardiac arrest survival, but We've got growing evidence that we've kind of extracted from these multi-item tools that suggest that actually survivors do experience severe mobility and restrictions in usual activities, reported in up to 50% of survivors at 12 months. Surprisingly, pain has also received very little attention, but high levels have been reported in hospital cardiac arrest survivors. So speaking to Lars's presentation, in more than 60% of survivors. And interestingly, pain reported in out-of-hospital cardiac arrest survivors seems to go up by 12 months. So a greater percentage are reporting pain at 12 months. There's a growing recognition of the importance of fatigue in this population as well, with high levels reported at 12 months post-arrest. But again, guidance for the assessment of pain and the assessment of fatigue is currently lacking, so we don't have as clear a picture as perhaps we would like. And then finally, social participation and community reintegration. By 12 months, most are living independently, but they face significant barriers. And often these barriers are associated with fatigue and cognitive and emotional difficulties, but also about the lack of support and security that people experience once they've been discharged to home. So in summary, it was just to say that it's clear that cardiac arrest survivors experience significant impairments, and we should be very cognizant of more detailed and considered assessment to really understand better the outcomes that really, really matter, and using that evidence to inform the kind of rehabilitation that this group really needs moving forward, and speaking not only just to the needs of survivors, but also their family networks who don't get an awful lot of support. I can see that you've appeared, JT, so I'm suggesting that you want me to be quiet now.
Because you thank you so much. We will have some time for the discussion later, and I can see in the online chat that there are a lot of questions so far. So I think we will have a very good discussion at the end. And Kirsty, we will just hear Siobhan. She will summarize something from Karen, due to the fact that Karen is in and from Australia. It's 3 o'clock in the night, I suggest. And she asked us not to be live on stage this afternoon. So Siobhan, my co-moderator, will summarize the presentation of Karen. Karen, and again, for everyone who needs the original presentations, please see on the webpage, you can see all the slides. They're online available. And now, Siobhan, it's yours.
Thank you, Jan Thorsten. I hope that everyone has had a chance to watch Karen Smith's presentation, but as Jan Thorsten said, it's available and well worth watching. One of the things that Karen highlights is that globally, we seem to be sitting around 10% overall survival, but at a local or at a national level, there's huge variation in reported survival. One of the things that we can't get away from is the fact that a proportion of this variation is down to differences in the robustness of different data collection systems. And as Ingvild pointed out, registries are often at different stages of maturity with different levels of coverage, so that's a factor. As we find ourselves in Eureka with our when is a bystander not a bystander anymore survey, there are definitional variations even at a local level. The patient selection for inclusion in the data collection system is a really complex thing. And ultimately, in most systems, it comes down to whether the EMS on the scene identifies that a cardiac arrest has occurred and reports that to a data collection process. Also, Karen highlighted that a lack of data set linkage also means that the quality and the comprehensiveness of data is adding to the issue of variation. But that aside, even with those problems, we do have Utstein, and the Utstein variables are regularly used to help to explain variation. Karen describes Kylie Dyson's paper in Resuscitation, which used data from 12 registries across 4 continents to estimate how much variation could be explained by the Utstein variables. And it was estimated that about 51% of differences in outcomes could be explained by the Utstein variables. So in terms of modeling, a 51% explanation of variation is not bad when compared to some models, and particularly if you consider how few variables we're talking about. But on the flip side, that means that there's almost 50% of differences in outcomes that are basically in a black box. Karen also highlighted the work of Brian McNally and the CARES registry in the US, which to date has over 500,000 cardiac arrest reports. So it's a pretty sizable database. One thing that Karen highlighted in talking about CARES was the fact that CARES uses the same annual report template as the Victorian Registry in Australia. And just a simple act of using the same template allows for direct comparison of results from different sides of the world. Karen's presentation was completed by advocating for the importance of measuring outcomes beyond survival, and she very much echoed Kirsty's point that multiple measurement tools of impact on life and quality of life after out-of-hospital cardiac arrest are necessary if you're going to have a meaningful picture of what survival means for patients and their families. And she concluded her presentation by summarising that globally, survival tends to be similar at an aggregate level, but there's significant variation at regional level, that the Utstein variables explain some, but not all of the variation, and that we should all be moving towards measuring quality of life as part of our core data collection process. Thank you, Jan Thorsten.
Thank you, Siobhan, for giving us that summarize of the presentation of Karen. And I invite Kirsty, Lars, and Ingrid to turn on their camera again. And I'm more than happy to see a lot of questions there on the screen. Siobhan, do you see them also? You have to turn on your mic again, then we can also hear you. This is much easier then.
Okay, yes, I can indeed.
We can do it as question by question, and just to personally think Leo Bossert is also in this session. Welcome to Leo, and we're happy that we have you with us. And maybe we can try to put the questions a little bit in a row, but maybe we can start with a question from Leo that goes to Kirsty. Kirsty, Leo is asking, could it be considered to register CPC 1 and 2 separately? So was the question coming from Leo.
I'm sorry, I'm not sure I understand the question. Would it be useful to separate the CPC 1 and 2?
Yep.
I think, JT, you probably know my response to this anyway. I think there are problems with the CPC full stop, because it tries to aggregate a whole range of different concepts within a very simplistic score. So I'm not sure I'd advocate the CPC at all. And I think there is guidance to suggest that if you want that kind of neurological assessment, I suppose it's kind of considered that neurofunctional assessment, isn't it, that you'd actually be better placed to use a modified ranking score. But I think in using the CPC, we need to think about what it is that we're trying to assess with the CPC, and if it could be better served by using a different kind of assessment. So people often use it as a kind of proxy for cognitive function, for example, and it really isn't a measure of cognitive function at all. And I think the evidence from, for example, from Gisela Leger's work suggests that actually, you can see quite clearly that when you've got a more comprehensive assessment of cognitive impairment, the CPC just doesn't work. So I'm not sure I'd put effort into separating the CPC into 1 and 2. I'd think more clearly about what it is I want to assess and how best to do that. Thank you, Leo.
And Kirsty, Jan Thorsten, if you don't mind, I just wanted to ask Kirsty in relation to the CPC, do you think it serves any kind of purpose at a population level to give you some kind of indication of how your cardiac arrest population has done after their cardiac arrest?
So I think, again, I hesitate to totally criticize the CPC because it's so widely used, and I think there is an innate kind of understanding as to what people get from the CPC. It's used so often in communication that I can see that it has value. But again, as somebody who is in measurement and wanting to understand that measurement is communicating accurate, relevant, high quality, robust information that will allow us to make clear decisions about how we move forward, then I think there is a problem we've been using the CPC at that global level, because we're making decisions based upon it. And it's a similar conversation around using generic measures to say, oh, look, that there's an acceptable quality of life in survivors, where actually if you unpack that generic measure and say, okay, so broadly, they seem to be okay, but we only have to dig a little bit below the surface to recognize that there are significant problems. And you can see that within the CPC as well. So I think many of these measures were developed quite some time ago. They're legacy measures, and so they kind of represent the way people thought about measurement at a point in the past, which was totally fine. But I think we're, particularly moving forward and really wanting to understand better what the needs and the expectations and the experiences are of survivors, so that we can appropriately appoint and provide healthcare that is relevant to their needs at a time that is timely to their needs and it's targeted, then we need to be far more accurate in the way in which we're gathering that information. And that requires us to really delve deeper into conceptualizing or establishing a much clearer blueprint about what it is that we're measuring, and then seeking to measure it accurately, so that when we're looking at data in registries, data in clinical trials, data in routine practice, it's data that we can actually be proud of, because it's measuring something, it's measuring the right thing in the right way with high quality data.
Thanks, Kirsty. Thank you. Jan Thorsten, I'll ask another question to Lars. Therese Jarv has had many questions here for you about in-hospital cardiac arrest. One of them being, do you believe that we have too many in-hospital cardiac arrests? How much lower can we go? And of course, how can we do it?
Well, that's an excellent question. Of course, we have too many. I don't think there is any number that is sort of acceptable. The AHA, I think, has a very ambitious goal of 0 out-of-hospital cardiac arrests by some time in the future. So why not 0 in-hospital cardiac arrest? And of course, I think there are many different ways that you can lower the proportion of in-hospital cardiac arrest. An important thing is making sure that those who have a cardiac arrest do want resuscitation and do want to have the attempt of resuscitation. So make sure that you have your conversations with your patients, both on a sort of personal level as a clinician, but also as a system level, that you make sure that the preferences of the patients are sort of heard and accepted. But the more interesting thing is, of course, how we can sort of lower the number of patients who have a sort of unexpected cardiac arrest, where we really want to try to attempt to resuscitate that patient. And I think there are a number of different ways to go about it. There's been a lot of focus for a long time on early warning scores, rapid response teams, and at least in clinical trials, they have had sort of limited impact. There's probably some benefit of rapid response teams, but it's not the golden era that we all hoped it would be, that it could really save a lot of lives. So I think we have to sort of think out of the box, think about new things. I think monitoring, ECG monitoring, all of form of monitoring is an exciting avenue, and especially with sort of more advanced technology, wearable technology, cheaper devices, I think there's definitely something to gain there. We do know that in-hospital cardiac arrests that are witnessed or that are monitored and have early CPR, early defibrillation, early advanced treatment do better. So I definitely think there are many ways that we can lower the rate even further.
Just one other part of Therese's question was about what's the correct denominator for in-hospital cardiac arrest. Would you suggest by patients or by beds?
Yeah, so another good question. I haven't really figured that one out myself yet, so I'm not sure I'll sort of come up with any definitive recommendation. I think even figuring out there's both. So counting in-hospital cardiac arrest is one thing, and that's actually hard enough in itself, but then calculating the incidence, you have to come up with 2 numbers, denominator and denominator. So I think we have done it differently in different papers. I think a good one is to simply look at the number of hospitalizations, but of course you have to get into details. What is a hospitalization? So the easiest and sort of cleanest thing would probably be to compare it to the adult population, for example, or the pediatric population within a country, because that's a more easily defined number. But as you saw in my presentation, there is a huge variation, and that's probably mostly based on the way we calculate things and not real differences. At least that's my take on it.
Okay, so I try to summarize the questions a little bit, but I start with a very interesting thing to Ingvild, and one of the very detailed readers asked the question, is there more outcome with CPR and ventilation in your Eureka data analysis? So a technical question to the Eureka 2 results. Maybe we can start with this.
Absolutely, and it's a very, very good question. We just summarized some of the results, and in our first article, in Eureka 2 article, we found a higher survival if the patient received both compression and ventilation compared to compressions only. We have now done a sub-analysis and really looked into the data, and we are currently writing on the last part of the article. Still more very interesting information to come, but on first view, it looks as if compressions and ventilations is better for the patient than compressions only.
Thank you, Ingrid. And last, maybe a question for both of you coming from Leo Bossert, this question. Can you comment on the progress of survival since the 80s? So there was a publication by Eisenberg about the tale of 27 cities. There's a paper from Johan Herlitz, about tale of 7 cities. We have Eureka. We have some impact during the last years. And Leo is asking us any comment about the progress on survival, however you call and define survival.
Well, happy or unfortunately, I don't remember the 80s. But if you do look at what happens, I think maybe survival is not the most important part to measure, but actually comparing apples to apples. Taking registries that count the same thing and comparing them to the same systems and the same areas. This means you can actually improve. What we found in the Eureka study was that we don't really know for sure what we're counting. And we found that quite a lot of regions in Europe are not able to deliver 30-day survival data. So this is it's a bit difficult to answer, but it's still an interesting question.
Of course, Lars, any comment from you to that?
Yeah, so I very much agree with that it's very challenging to compare outcomes across studies and across different time periods and across different countries. There has been a huge development in cardiac arrest research, but also the clinical treatment of cardiac arrest patients over the last 20 or 30 years. So the patient population might also have changed. Patients 30 years ago that would have been declared dead right away might now receive resuscitation and therefore be included in these numbers. So it's very challenging to sort of compare across different studies. We did look at the CARES registry this year, where we looked at outcomes over the last 6 or 7 years, from 2013 to 2019. And actually there has been no improvement in outcomes in that time period, which was a bit surprising to us and also a little bit depressing. It's very similar to the results I showed for in-hospital cardiac arrest. So I think a lot have happened in cardiac arrest clinical treatment, including bystander CPR, early defibrillation, things like that. But we are perhaps reaching some plateau now where we need to sort of think outside the box, develop new treatments, making sure we recognize cardiac arrest earlier. And so I think the numbers are in one way a little depressing because we haven't seen an improvement over the last 5 or 10 years, but in other ways it's also encouraging us as researchers and clinicians to sort of focus even more on this patient population and trying to get even better outcomes, both the outcomes reported here, but of course also the outcomes as described by Kirsty, looking at cognition, quality of life, and patient-centered outcomes.
If I may just make a last comment, also we need to look at how we count. Percentages might not be the best way to look at results. Same as you said for the in-hospital cardiac arrest, we might need to look at resuscitation per hospital beds, and for out of hospital, how many cardiac arrests do you have per 100,000 inhabitants?
We have a question here from Jazz for Kirsty. Jazz is interested to hear your opinion on the value of ROSC as an outcome.
Oh golly, I'm not sure I'm in a position to really provide an authoritative view on ROSC as an outcome. Certainly in the work leading up to the COSCA work, there was a significant variation in the way in which ROSC was captured and reported. I'm not sure, Jazz, I'm sorry, I'm in a position to say whether or not I think it's a good outcome or not. I think it has its value and it has its worth, and I think there are other people who would be able to comment more.
I think, sorry, actually, Kirsty, I think Jazz's question was in relation to perhaps the value of ROSC to give relations the opportunity to say goodbye, etc., where ROSC may not lead to a good longer term outcome. Maybe the other panelists would also like to join in on this question.
It's a great question, Jazz. I mean, I think it's something that it would be valuable to look at to see, you know, how one would interpret that to inform such critical decision making, actually, isn't it? That's,
yes, so I actually think it's a quite important question, and I think it's very important in the way that we also discuss these outcomes with the patients and relatives, because there's no doubt that if you do a survey and ask a patient, would you rather have a good neurological outcome with a happy life, or would you rather not? Everyone will say that's what I want, but that might not be the option. The option might be, do you want to have return of spontaneous circulation and then die 3 days later, or do you want to die right now? And that's a little sort of harsh, but that is sometimes the situation we are in. And or do you want to have return of spontaneous circulation such that you might want to be an organ donor? And this is especially important in light of recent results for epinephrine, for example, where very few patients survived, and very few patients survived with a good neurological outcome defined by the modified ranking. But there might be other values in short-term survival, both from a global perspective and organ donation, but also from a personal patient perspective, as Jazz mentioned, sort of giving the family time to say goodbye. I don't know if that has value, and it's not my decision to make, but it's interesting from a research perspective that we might have to include things like that going forward. And of course, there's also downsides to having only short-term survival in terms of cost and other things.
Thank you both.
And if you look at the discussion, there are a lot of questions dealing with what is the outcome? Is it ROS, the sustained ROS, the first ROS? And we can only analyze what we collect and just ask us what changes should be maybe made to the Utstein protocol. And I think this is a question that goes to every one of us. And another, colleague asked, it's Janet Bray. Hi, Janet. She asked if you can put one additional outcome measurement to the Utstein style, what would it be? So maybe we start with the first. Do we need a change in the way how we collect data following the Utstein style? So do we need a new Utstein style, and maybe it's more impression than a direct answer? And we can start with Ingrid. What do you think about Utstein? Is it good enough 6 years later, or do we need new variables? As we learned from the paper from Karen, that only 50% are usable for prognostication. What do you think?
New variables in the Utstein group, only if we can remove two. If we add one, remove two. I think there are too many variables already. If we do research, we can, of course, collect a lot of information. But from a registry perspective, we actually need to reduce the number of core data points. And we need to listen to the people that are actually out there and make sure that what we're asking for is available. So my recommendation would be get some registry nerds in the group that actually does the Utstein update. And yes, it needs an update.
Lars, what do you think?
Well, I mean, the Utstein was almost just updated, so it will be a challenge if we have to update it again. I guess it's 5 years since the out-of-hospital cardiac arrest one was updated, but the in-hospital one has just been updated as well. I think the Utstein is a great starting point to sort of say, what do we as the cardiac arrest community consider to be important variables, sort of basic things. But it shouldn't be a one-size-fits-all. As Ingrid was also saying, it really depends on the setting. I also work with the Danish in-hospital cardiac arrest registry, and we have everything on one page, like everything can fit on one page. And that's great for that type of work. But I also run clinical trials where we collect 30 pages of data. So it is really important what kind of question you're answering. If you're trying to figure out if a drug has some effect on return of spontaneous circulation, it's a small trial, phase 2 trial, then perhaps you don't need to collect 1 year cognitive function. It's just a matter of resources compared to what kind of question you're asking. Of course, if you're doing a phase 3 trial, thousands of patients, this is going to change management of cardiac arrest patients. Well, then, of course, you collect all that intense data, but that is also very, very resource intensive. So I think we have to not try to make Utstein sort of a one size fits all, and then instead sort of tailor it to the research question or the population registry question you have.
Kirsty, what do you think?
Okay, so I think, I mean, I agree with what Ingvild and Lars are saying, and I think the need for consistency is clearly really important, and that's very much what Koska spoke to too. The need to have some clarity that all registries are collecting the same information, or the same information has been collected across different studies, so that we could have this comparison, as Ingvild said, of apples and apples and pears, as opposed to different fruit salads where it's very difficult to compare that evidence. But again, picking up on what Ingvild said, that there is that resource issue that makes it far more challenging to get that data. And as you know, JT, I'm always going to say, but I want some patient-reported outcome information in there as well. So my hat is always going to be hung up on saying, okay, but where's the patient's voice in this? And patient-reported outcomes do feature as a very tiny element of Utstein. But I think for me, moving forward, that's where we've got to think more broadly about how we enable that to happen. And I think with new technologies and remote collection of data, I think it is becoming easier and more acceptable, and perhaps more expected from the survivor to have a voice in what's going on and what data is collected, but taking on board all the different challenges that have already been mentioned before.
Thank you, Christy. Siobhan, what's your opinion about that?
I think that one of the things that we need to consider in the new Utstein data set, as shown by our own survey of when is a bystander not a bystander anymore, I think we really have to explore that whole area and that subtopic of how we classify the people who perform CPR or defibrillation before the EMS arrive. I think that's a very important consideration. Actually, on Kirsty's point about how we collect data on outcomes, I was actually thinking, had any of the other panelists any ideas about how we could incorporate the collection of data on patient-reported outcomes into routine data collection?
So shall I have a go on that for PROs? So I think increasingly, and I think, you know, COVID, there are almost silver linings to a lot of these challenges that are facing us, but the ability to engage with remote data collection, I think it is becoming more and more important. And there are numerous electronic platforms now that are available and competing for space, as it were, to enable people to have that remote completion of data, either on smartphones or tablets or by some kind of web-based link. And I think exploring those opportunities would be important for how we collect this data moving forward, and supporting the integration not only into clinical trials, into registries, but into routine practice scenarios as well. And there's lots of great evidence from other fields whereby the collection of this information remotely at a time that is appropriate for the individual it enhances communication, and it allows that access to timely care at a point of need, as opposed to waiting some time down the line where you may get an appointment with somebody and it may actually address some of your issues, but actually you are having a crisis sometime earlier. So I think it's a really exciting field, and there's lots of work going on in that area now. So hopefully watch this space. We're just, as JT knows, we're just in the process of starting this international collaboration to develop a new survivor-reported outcome measure of survivorship and quality of life, and certainly exploring an electronic platform to support that will be a really crucial part of that process.
Yeah, Christy, thank you. And I just see a comment from Rudy. Hi, Rudy. He said, don't forget that the Utstein is a basic framework and not designed for research. And I think it's an important thing that over the last years, a lot of us in registry try to combine both, or do both. Quality management on the one hand side, research on the other hand side. And if you have an answer like a yes and no in the bystander questions, years ago, we were happy with a yes or no. Now we know we can ask 50 questions, but we can't ask those 50 questions night shift at 3 o'clock to an EMS emergency physician or a paramedic. So we must find a good way, and I love that idea, Kirsty, of getting data, what is there really existing, and what we can use from machines, from other things, that people mustn't fill out too many forms. Nevertheless, I think if we have no data, or we have only a was good or not good, the binary thing is very nice to compare, but not very detailed. And so when I look at some questions, do we need more information about the place and the location and so on? I think this is something what we have to figure out. And I really love that idea of ILCOR, that they're talking about a combination of what is achievable, what can be collected on daily basis, what could be maybe as an additional module or whatever for specific questions. But there are a lot of questions in the question section that ask, is it possible to do a worldwide overview? But then again, if you just say yes or no, it's easy. But then, as we know from a lot of colleagues, the limitation section will be longer than the paper. So there is a good chance to do more, but to be honest, as Ingrid said, if we add 10 more variables, we have the problem that no one will fill them out on daily basis, and we need the participation and the support from our physicians, paramedics that deliver that data. Okay, so I check the next questions, and maybe Shimon, you can continue.
We have had quite a few questions, I think, around that idea that Utstein is often used more often for quality improvement and not necessarily for research. So we had a few questions there about whether we could have some form of a summary score that gives us some indication of neurological function that would be better than CPC. Would any of the panelists have any ideas about whether a summary score would be possible, or would it be the right thing to do when you're thinking of things from a quality improvement perspective rather than the individual patient?
So I don't have the answer for your question, but I'd like to say that if we start small in registries, start with few variables, get the information flowing, and then in time, as the registry matures, of course, you need to look at quality of life. How do we handle our survivors? This is improving quality and following patients up. In my speak, I talk about a lady in Norway that had cardiac arrest at the age of 37. And she thought she was really all well and went home and started to function at home, and it really didn't work out. But she was a CPC1. She could get dressed, she talked to people, she looked well. But then when she came home, she could only cook with one pot at the time, because she could only handle one pot with potatoes, and then she did the meat, and then she did the vegetables. So it wasn't really working. So following these patients up to improve their quality of life, but also to actually know what we need to change is important. So just getting any kind of tool to collect, I don't think that's the way to go. I think we need to know where we want to go by using this tool. Otherwise, the tool is useless in itself. Not useless, but yeah.
So can I jump in with that? So I think everything you're saying, Ingvild, is absolutely right, and I totally echo that. And I think it is that sense of engaging with survivors to really find out what the issues are, what the challenges are, so we have a much better sense of the kind of outcomes that we need to understand, you know, the outcomes that matter moving forward, so that when we craft and we don't have a measure available to us at the moment that allows us to do that. You know, the measures that we have are rather blunt tools, and they're giving us a really quite a full sense of what the needs are of this growing and vulnerable group of survivors. You know, we've done a great job at improving survival rates, but now we need to do an even better job of improving their survivorship. And so hopefully, you know, the work that we're now working on to develop a measure will allow us to do that. And it's not beyond reason that actually, you know, we can create a measure that has all the bells and whistles, that is really kind of comprehensive and would be very useful for routine practice and for potentially research. But actually then we could have a shorter version that would be more acceptable for registry completion, for example, so that, you know, it reduced the onus on the kind of amount of data that's collected. But I think by engaging with the community, survivors and health professionals and researchers and people who are involved in registries, which is what we're trying to do, we'll hopefully take on board those different stakeholders' perspectives. So ultimately we will end up with a measure that is owned by the community, and the community wants to use and integrate within their practice. That's kind of the big vision, as it were.
Okay, thank you. I just had a question to Lars. In your presentation, Lars, you made the point that there was a vast difference in the percentage survival between the Danish registry and the US registry. Would you care to speculate on the reason for that? I
would rather not, I think, but No, so as I said, it is challenging to compare outcomes, incidents, characteristics across registries, because things are defined differently, and there's also different cultures surrounding many things, surrounding do not resuscitate orders, surrounding registration, like what events are registered and which are not. A good example is whether someone calls a cardiac arrest on the floor, or this could also be out in society, and when the cardiac arrest team arrives, the patient does not have cardiac arrest. So either that's because the patient never had a cardiac arrest, or the early efforts sort of took them out of their cardiac arrest. So that's two extremely different situations. And if you just call a lot of cardiac arrests and include all of them and they all do great, then you'll have better outcomes. So I think it's very, very challenging. So I prefer not to comment on country differences, sort of just based on those numbers.
I think you did in your presentation refer to the fact that some patients who have a pulse would be classified as cardiac arrest.
Yeah, so that would be a good example of, for example, if the nurse on the floor is not very familiar with cardiac arrest and checking pulses, they might call a cardiac arrest. And in one register that might be a cardiac arrest, where in the other you need to they need to be pulses. And so there might be some slight differences, and sometimes these definitions are sort of hidden in the supplemental material on page 48, and you sort of really have to be careful when you're comparing against different studies, different countries, different registries.
Okay. Perfect, thank you.
Just check the next questions. Are we happy with, there's a technical question, I think also to Lars, dealing with this time interval and the Utstein of in-hospital cardiac arrest. I'm unsure, no, we didn't answer that before. So Lars, maybe it's a technical question coming from John Stewart. He's asking why the time intervals are out or disappeared from the latest revision of the Utstein in-hospital guidelines. Do we have an idea why this disappeared?
Yeah, so it did not disappear. I was a part of the writing committee, but it is less pronounced. I will say that. So I think I've spent a lot of time thinking about time in cardiac arrest, too much, I think. But as a researcher who is interested in ALS interventions and are interested in using large registries to try to answer causal questions, to try to understand which treatment works and does not work, time is absolutely essential. And we sort of described this concept of resuscitation time bias, which is sort of just a technical term for that time is important if you have to compare treatments during cardiac arrest. So I'm absolutely a proponent of including time in whatever data collection you do. But as the clinician being out there seeing these patients, I also realize how extremely difficult this is. Hopefully going forward, there will be better technology that will enable us. I mean, the technology is already there, but it's just not implemented. That will be able to register time much more precisely, such that we can better use the data to look at some of these things and look at how much time actually matters. But there's a long way to go, but it is really important. But again, it depends on what your research question is. If you're interested in describing the patient population and outcomes in a descriptive way, well, then it's a lot of work for not that much gain. Are you interested in a very specific research question like, is epinephrine better than no epinephrine? Well, then you need detailed data on that epinephrine administration, including time, dose, the way it was administered, and so many other things. So it really depends on your research question, which also means that we have to be very careful to use these registries to try to answer all our questions, because they're just not suited for that.
And then when it comes to answering the questions about what impacts survival, some of the audience have been asking, how much do the panel think that post-resuscitation care impacts on survival? Because that's obviously one of the measures that wouldn't have been available in Kylie Dyson's estimation of how well the Utstein factors predicted survival. Would anyone care to speculate on what type of impact post-resuscitation care would have on survival?
7%. No, I don't know. I don't know what the number is, but of course, we don't know a lot yet about what kind of post-cardiac arrest treatments really affect outcomes. We have a pretty good idea about some of the pre-hospital factors, such as bystander CPR, AED use, cardiac arrest being witnessed, and more demographic factors. But the post-cardiac arrest area is a growing field. There is a lot of randomized clinical trials ongoing. So I think we'll see, as we have seen the last 10 years, a lot of good trials. We'll see even more going forward. I do think it matters. I'm also working in ICU, so it would be
hope it matters.
Yeah, stupid to say anything else. But of course, if the damage is really done, like if there is irreversible brain damage, there is probably not much we can do. So for some patients, I think it makes a huge difference. For some, it makes no difference. But that's the way medicine is in general. So there's nothing specific about that here.
Thank you.
Yeah, so I'm just looking for the last minutes of our fantastic session, and I just wrote to Siobhan, I'm starting loving that tool. So at the beginning, I was a little bit unsure if this is a really good format, but it's a perfect discussion without seeing people. So normally I don't expect that it will be so good. I will look at the last questions, what we have on our screen. So some of the questions were so detailed that I asked the colleagues to contact the speakers directly. So maybe Kirsty, Lars, and Ingrid, you got emails from colleagues that they come with specific questions. But there is, of course, at this stage, at this time, a question about COVID-19 is nothing for our epidemiology thing, but I think what we discussed in all the registries during the last meetings, also on Tuesday on this worldwide registry meeting, that every one of us is collecting data, looking on the impact of COVID-19, and there are coming some specific questions about ventilation. Should we use it? There are questions about bystanders and the impact on the guidelines. And the critical colleague said, okay, all the years before, we don't talk about influenza, no one about tuberculosis, but on COVID, we say there is a problem. So maybe there's more statements than questions, but maybe I can ask a question to every one of us with a very short answer. What do you think? Can epistries, guideline epistries, and registries help to understand in the circumstance of COVID? Is it helpful, or is it just a peak in the in our statistic? What do you think will be measurable? What can we do with registries and epistries during that time? Just producing a next paper and saying it's different to the next month, or really scientific knowledge? Okay, I know it's provocative, but Kirsty, will you start with a short answer?
I'm not sure I have an answer for that, JT. I think that's somewhat outside of my scope of expertise. So I'm going to pass that ball on that way.
Okay. And the word goes to Lars.
So I think it's a very interesting question, and of course we will see many COVID-19 publications. We already are, and we will see even more over the last 5 years. I think we as a community have to be careful not to publish 20 COVID papers that all look alike, that has limited sort of importance to the patients. But that said, I do think there are some important questions that can be answered. We just have to be very careful. One of the issues, or one of the reasons I really haven't looked much at it, is that I'm very concerned whether, for example, incidence is changing of cardiac arrest, or it's the registration of cardiac arrest that has changed. Like a very busy hospital full of patients that might see more or less in hospital cardiac arrest. I think it's a very challenging thing to address. But we have seen some interesting publication coming out already, how COVID has influenced out-of-hospital cardiac arrest rates, for example. So I do think there's some interesting stuff there. But there is also many other research questions to address, so we just have to be careful not to be sort of sucked into the COVID-19 research theme.
Thank you. Ingrid, what do you think? Are the Norwegians planning data analysis about COVID-19 and resuscitation?
Well, as you know, yes, we are planning to look at this, but we're not planning to look at it alone. We'd really like to look at this in more of a meta-analysis perspective and sort of collect information from all the different registries and cooperate and see what's really going on. And using incidence and not percentage is very important. We also need to remember that 70% of all out-of-hospital cardiac arrests happen at home, which means that the person that is there probably has been breathing the same air as the patient all the time anyway. So what we have to look even more at is actually the PPE, the personal protection equipment that the ambulance personnel have to put on, and the extra time it takes for the ambulance to arrive on the patient's side. That is probably more interesting than the COVID-19 in itself. But yes, I think we should look at it. I think we should collect the information, and I'd like everybody to cooperate. I think that was what you were looking for.
Siobhan, the island perspective. You don't have COVID on your island.
We won't talk about that today. Thank you very much. No.
Okay.
But no, I think that it's really one thing that the pandemic has brought up is that we've had a global public health measure that has been recommended for almost every country in the world. And we have another public health measure which recommends that people do bystander CPR in the event of cardiac arrest. And I think it's very interesting to see two public health measures that are at odds with each other at the minute. I think to me that the public health impact of COVID-19 and the impact it has on the first two links in the chain of survival, particularly bystander CPR, I think that's going to be a very interesting analysis when we eventually start to get to the other side of this pandemic.
Okay, Siobhan, thank you very much. And I think now it's exactly 1 hour ago when we started this session. I'm really impressed by the speakers and the presentation, but also by the many questions what we got via the chat. So thanks again to the audience for this really good questions. And again, if you have specific questions, please contact the speakers directly. And I have a last question from Jess. He's asking what's about the next Eureka project. I can say tomorrow is also next day. Tomorrow we have Friday. We have Friday on the ERC Congress. There will be a ResearchNet session in the afternoon. Any one of you who wants to know more about the Eureka project should join the ResearchNet session, and then you will know more. Okay. I say thank you for the participants. I say thank you to all of the audience, and I hope you enjoyed the session as much as I did. And I wish you a nice evening. There are some things on the program on the agenda tonight, and of course on the next days. So enjoy the virtual Congress of the ERC, and at the end, do more and serve more lives. Thank you, and have a good evening.
Thank you, everyone.
Bye-bye.
Thank you. Bye.